When you go through ketamine, and when I went through ketamine, I had a perspective that I had never been able to force myself into, to see it for what it is.
Some are calling ketamine therapy a miracle drug, helping with pain,
I was like pain-free for 3 months.
PTSD, and depression.
That was most encouraging for me, is to see the positive input that I've gotten.
But is it safe?
So considering the death of Matthew Perry and how it's been in the headlines, how do you ensure that the ketamine use serve at your clinic is a safe amount? Do you think for anyone this could become addictive for them if they might crave it outside of the clinical setting? So have you ever had anyone that had a bad experience from taking ketamine?
Welcome to the Wellness Files, a podcast where we explore practical tools, research, and real stories. I'm your host, Carrie Beal, and today we're sitting down with Dr. Tim Osbon.
All right, we are here with Dr. Tim Osbon, so thank you so much for joining us today.
Thank you for having me.
I want to go on a little bit of background on who you are, kind of where you practice. But first I want to start with, you used to be an ER doctor, correct?
I still am.
And you still are?
Yeah, I am.
Okay.
I'm an attending at the VA Medical Center in Charleston, though I've begun to step back from that a little bit. One of the things that I started in March of 2020, right before the pandemic was declared, was at a ketamine infusion center here in Greenville, because I grew up in this area. I grew up, born and raised in Greer, so I know the Greenville area very well. And I've used ketamine in my practice in emergency medicine all of my career.
Now, as an anesthetic? Or
as a sedative and anesthetic for treating issues from tongue lacerations to set bones and things like that. So I've used it in that way a long, long time. I had a traumatic brain injury and unfortunately a few seizures a few years ago. So I had some time and I began to kind of look for something else to learn about. And ketamine was one of those things that really intrigued me when it's used the way we do in Greenville. And so there's a gentleman named Dr. Richard Bowen in Charleston. He started the Charleston Ketamine Center, and I had a couple of months there that were free, so I went and volunteered and spent some time with him, learned how you can use ketamine in an outpatient setting, not just in the emergency setting.
Yeah, because I think it's important for people to point out it's FDA approved for as an anesthetic or something that puts you under. It's currently off-label for the purposes you're talking about for depression, and we'll get to that later.
Yeah.
But I think that's important to point out. That's why it was used in the hospital setting.
Absolutely. I used it on a daily basis and was very comfortable with it in that setting because it is a very safe drug, and I'm sure we'll talk more about that, especially in the outpatient setting. Mm-hmm. But it facilitates so much that I need to do in emergency medicine that can be painful procedures and that sort of thing. But seeing what I saw in Charleston with Dr. Bowen and learning that, I really just kind of came down to the question of how can I not do this, especially in a place that I grew up, and I have family here, some that needed treatment. So it really evolved to develop the idea to do a clinic like we have in Greenville. Started that just before the pandemic, and we did well during the pandemic because it was considered essential. And we've seen great success, and we'll go into that a little bit later, I'm sure. But it is one of the most edifying things I've ever done as a physician, to see the changes that can be wrought and brought about with ketamine as a part of their therapy. And it's been wonderful to see, really, and this is a word I use advisedly, is miraculous in patients. Wow. And I think you had sent me some videos to look of patients that have been treated and you've interviewed, and I can attest that those testimonials are true for most of our patients. It's because ketamine is such a useful drug in the realms of refractory depression, PTSD, OCD, substance use disorders, amongst a lot of other things. Chronic pain for sure.
Yeah. Now, I do want to get to the safety of ketamine, making sure you use it in a safe way because of the death of Matthew Perry.
Absolutely.
But before I get to that, I want to give people a little bit of your background. So you're the person who actually administers the ketamine in your clinic, correct?
Myself, I have two physician colleagues,
okay.
And we also have a nurse practitioner who's trained in the use of ketamine, as well as kind of the psychotherapeutic approaches to treating these issues. So a lot of times our nurse practitioner will be in the room. We have all of our staff are trained to be able to at least start that thing, but we have to supervise and observe and make sure we're monitoring the patient, and we do that. It is an extremely safe drug. In fact, I've told many patients it's the safest drug I've ever used in my career. Wow. However, we add to that safety margin. We monitor the oxygen levels, the blood pressure, and the heart rate, just to add another level of safety to what we do.
So that's what you do in the clinic, you
Absolutely.
Monitor
Absolutely.
all of that. So considering the death of Matthew Perry and how it's been in the headlines, how do you ensure that the ketamine you serve at your clinic is a safe amount?
Well, we use the lowest dose we need to get the effect that we're looking for. And when it comes to treating refractory depression and the things that we treat in our office, you don't need much because we're, for the most part, delivering this intravenously. So in medicine, we would say the bioavailability of that is 100%. So 100% of what we're putting in is going to work and do its thing in the brain, and it will affect your perceptions and your senses and all that sort of thing. So we can adjust that. We can adjust the dose by making it a very small dose, and we can also adjust the rate. So we want that patient to get the infusion and have the dissociated experience where they literally have a kind of a separation of mind and body, because we know from the literature and from our own experience is that we know that's a good proxy for giving a therapeutic dose. And what the therapeutic dose does in very rapid fashion, far faster than any of the other medications like Prozac and the other SSRIs, is that when we give that therapeutic dose, what happens in response in the brain, especially in the areas that are most important for affect and mood and those sorts of things, is there is what's called synaptogenesis, kind of a fancy term for the interconnections of the brain that have fallen apart under the chronic stress of refractory depression or PTSD or other mental health disorders. The interleaving of the neurons kind of falls apart, and they interleave at a thing called dendritic spines. What we know in response to even the first dose of ketamine is those spines increase in number, and so the interconnections increase. And we think that's the clinical explanation for why fundamentally a patient's thinking changes. And it's what we see in a very rapid fashion. As I mentioned, oftentimes in our clinic, we do a series of 6 to 7 infusions fairly rapidly in about 2 or 3 weeks. And we do that because each builds on the last, but we also get a very quick understanding of whether or not a patient is going to respond to that medication. Usually 3, 4, and 5 is what I tell patients. Some patients have the very first one. But the sweet spot for us is 3, 4, and 5 to determine, is this making a difference in your life? Are you processing the problems that life throws at you differently? Or is it doing nothing at all? So we want to gauge that early on in the process and determine if someone is a responder to ketamine. And if they're not, I don't ask them to waste their time, energy, or money on it. But the vast majority, in excess of 90% in our office in Greenville, have responded robustly, in fact, to ketamine infusions.
So have you ever had anyone that had a bad experience from taking ketamine?
Yes. That's the thing about the dissociated experience, right? We're giving a dose to get you there and let you kind of reside in that space for 40, 45 minutes for most of our treatments. And it can be a little bit, it can be problematic, it can be disconcerting for a patient. I'll give you an example. I had an elderly gentleman who came in for his first infusion, certainly met the criteria. We knew we could help him. His first infusion he described it as harrowing. So it was scary. He had a near-death experience, which is fairly commonly described.
What do you mean by near-death experience?
He felt like he had passed away and he had gone beyond the veil, as they describe it, and could not come back. Now, what happens is they quickly realize they're in a safe place. We're there checking on them. We're very soothing, touching their hand to let them know you're okay. And so for some patients, that would be a disqualifier. They say, I'm done, I'm not doing it anymore. I talked to him, he said, I'll be back. He came back the next time. His second infusion was, he said he talked to God. Quite literally had a nirvana, heavenly-like experience. So every infusion can be different. Very few are harrowing like that, but it's my duty to tell patients it can be scary because there is a lot of emotional processing that goes on, and there can be trauma that you relive to some extent. But what's happening is you are getting a therapeutic dose that will lend itself to a response that allows you to process those things differently later. And that's why we see a great response in most of our patients, and we see it last for a very long time until such time as we can get them on a maintenance dose where they don't need it every 2 or 3 days for the first 2 or 3 weeks. Hopefully they need it every 3 or 4 months. And that's a great outcome for a patient when they need to come to our office when they need it and not necessarily on a scheduled basis.
Yeah. So I actually want to listen to a patient's story. I want to bring up that I had a story air not too long ago with Keith Paris. So he's a nurse practitioner in Asheville who also administers ketamine, and he let us talk to one of his patients. She's been using ketamine for depression, and so I thought it was really great to hear her story and how it helped her. She did try 2 other antidepressants prior, and she just said they kind of weren't working as well. So we'll take a listen to her story.
Sure.
So you've been experiencing depression for how long?
Honestly, most of my life, I can remember experiencing feelings of depression, but pretty intensely since I had children, postpartum and then after. And that would have been, 25 years now. that I have been experiencing that.
So what have you tried so far, and how has that worked before you tried ketamine therapy?
Before I tried ketamine, I've tried various SSRIs and uh, pharmaceutical options, and would get some relief, but just never quite got to where I really wanted to be. Things would work for a while, and then it would feel like they would sort of poop out on me.
When you're feeling that way, what is it like for someone who maybe hasn't experienced depression? What's kind of going through your body? What's going through your mind when you're feeling depressed?
It just seems like everything feels like climbing Mount Everest, and it's hard to reach my goals that I really want. I feel a little, overreactive at times, overwhelmed when I do experience depression.
Does it make it harder to perform tasks, like go about your day?
Absolutely, absolutely. It seems like I get stuck in my head a lot and not able to perform my everyday tasks the way that I would like to.
Mm. So you were trying the other treatments, which are FDA approved treatments. At what point did you try ketamine and why?
I had gotten to the point where I felt like my depression was impacting my relationships in a way that I was not happy. I was feeling like I was starting to, impact my family in a negative way. I was very aware of that, and that gave me the extra incentive to try something else and to try to see if I could get a better treatment.
Did a healthcare provider recommend it for you?
No, I found it on my own, actually. And I did ask my healthcare provider about it, and he said, if that's the option that you feel, and let's try a couple more things. And if you're still not getting the results that you want, then we can try that. So I really initiated it on my own.
Hmm. So what's it like when you walk in? Kind of what's the process like?
It's wonderful. I'm taken into a very soothing room, a soft place, literally, figuratively, and mentally, to be where I can relax. An IV is administered, and my therapist, who has been so amazing with me in this process and such a central piece of that for me, is there with me by my side. But the IV is administered. I've given a blanket and an eye mask, and soothing music is played, and it just feels like a place to take the weight off.
So you have your therapist with you when you go have ketamine therapy.
I do.
Why did you decide to do it that way?
I really wanted the chance to be able to integrate what I was experiencing in my infusions. It's a very experiential process, and I felt like it would be even better if I could go over that with someone trusted, with a professional who was already familiar with me and who I have a good rapport with her, and just felt like that could help me utilize what I was experiencing within the ketamine session.
When you go through a session, what is it like? Like, what's going through your mind? I was kind of told it's a little bit of an out of body experience.
Mhm.
Can you describe that?
It is a little bit of an out of body experience. However, I will say I'm always very aware that I'm having an experience. I've never felt afraid or that I get out of touch with myself. It's a very unique experience. It's very relaxing, and I think what it does most is it gives me perspective on my life, on who I am. I feel my worth in a way that I don't always feel just in my everyday life.
Yeah. And then do you notice the benefit after you leave the session?
I do. I do that. When I first started out, I started out with a series of infusions, and it was a series of 6. And by about the fourth one, I noticed it was very subtle that I was handling things better in my life, that I was things that maybe might derail me before weren't doing that like the way that they used to. And so I have really benefited and continue to benefit from that. It helps to relieve my feelings of depression, and it's not. I don't get any negative side effects or any lingering strange feelings after it. It's just a way to sort of boost my capacities.
Have you
Mhm.
ever had a bad experience while you were having treatment?
Honestly, no.
Oh,
I have not. I've never felt in danger or no, even some of the infusions where I have had some very emotional experiences, those have proven really positive for me in helping to integrate them into my life.
do you think for anyone this could become addictive for them if they might crave it outside of the clinical setting?
I can speak for myself that I never have. I have never felt a craving for it.
Okay.
So I have found it very safe and never experienced any problems with addiction or craving.
Have you ever just stopped the treatment, or you've just been doing it for the last 3 years?
I've been doing roughly about every 6 weeks, I'll get a booster infusion. So no, I've never abruptly stopped it.
Hmm. Okay. So you don't know for sure if you would have any withdrawal if you stopped it at this point, correct?
Not after about 6 weeks.
Yeah, at least 6 weeks you didn't.
Mhm.
Um, and so you've been doing it for 3 years. What advice do you have for other people if they're considering this treatment?
I would not hesitate to tell anyone to try it if you feel that you could be helped. I think it's very exciting that we are in a place where we have access to this. It's a relatively new way of helping people with depression, PTSD, even addiction. So I definitely I would not have any hesitation to recommend it.
All right, great. You
Mhm.
said you're a mom. How many kids do
I
you have?
am. I have
How
two.
old are they?
They are 24 and 25.
Okay, so probably college
So
age or just first job or something like that.
college, yeah.
You've been doing this since they were in college. So,
Mhm.
have they noticed a difference?
They have.
Yeah.
In fact, I think that was most encouraging for me is to see the positive input that I've gotten from my family and the happiness that they have for how they see it's impacted my life in a way that has brought me a lot of happiness and satisfaction and given me a lot of hope, to be honest. So it's really been a positive impact on my whole family.
So yeah, I thought that patient had a very interesting story because she had tried other medications, nothing worked for her. So before we continue on, I want to go over again how this works in the brain for somebody who has depression. So she talked about antidepressants that increase the serotonin in our brain. But as you were saying, this works differently. And I kind of see it as it's like a battery that you get every time you get a session, kind of igniting the neurons, right? Kind of igniting some of the things that just weren't firing before.
Exactly.
That's how you kind of see it too?
It's almost like a reboot of a computer where things will process more efficiently and in a very different way. It is very different from the serotonin reuptake inhibitors, those sorts of things. It's, not to get too lost in the weeds, but ketamine acts on what's called the NMDA receptor, and it blocks that, and you get what's called a glutamate is increased, and it's a neurotransmitter much like norepinephrine.
So the glutamate increase, which is the firing transmitters.
Exactly, and it's also the cascade that occurs in response to that explains what I was just talking about, and those spikes that kind of regenerate and then explain the interconnectivity, which increases because it's in response to chronic stress of depression for 20, 30, 40 years on a lot of our patients. So that's what we think explains why it works so well. It is a very different mechanism of action. I would say that it works better. If you look at the literature on the SSRIs, there's not a whole lot been new since it was first introduced in the early 80s, and it's only slightly better than placebo. The studies on ketamine, we now have 25 good years of research on this for the treatment of things like depression. So it's not brand new.
Yeah.
I consider it mainstream, and it's so safe. And if it's done the right way, and obviously has been done poorly in other ways, but it was done the right way in a clinical setting where you feel comfortable and you know the staff there is looking after your best interests, and you have good therapy outside of that, to include a psychologist, psychiatrist, even a primary care doctor.
That was actually one of the things I wrote down. So cognitive behavioral therapy. You want to pair that kind of with this, or it's one of the things they recommend, right?
Absolutely. It not necessarily in the midst of the ketamine infusion. I know you sent me a thing about a patient who had their therapist with them.
Yeah,
and we've
actually
had
this
that.
patient, she had her therapist there.
So,
yeah.
and we've tried that. Ketamine is not the greatest medication to deliver in the way we do, and to have that talk therapy work as well, just because it can be so disoriented, And
But could it be like a comfort, like just having somebody,
absolutely,
whether it's a therapist or a family member,
yes,
or somebody that makes you feel comfortable
always,
in case something happens, as you said, because some people do have a bad reaction. And I actually wanted to ask you about that. So I've heard anecdotally that people who have never had an out-of-body experience before, so maybe they've never done drugs, they've never done alcohol, those are the people that might not respond as well to ketamine, or at least the first session. Have you ever heard that?
I have, because they've never had the phenomenon of maybe taking an intoxicating substance of some sort and kind of being out of control. Mm-hmm. And so for the first time, if they do ketamine, they've never had that experience, it does feel very disconcerting. So I agree. There are patients who have lived the life of a teetotaler, and for the first time, the ketamine is doing what it does, and it is a surreal experience. Yeah. I always tell patients, I say, this is going to be weird. I tell them, you're about to go to La La Land. I use terms like that to kind of soften it, because it is different. And you're right, for patients who've never done anything like that, it's going to be a little weird, but our job in our clinic is to make you feel comfortable, to let you know that it's safe, and we're going to be watching. You mentioned having a family member. That's very helpful for someone like that, because even in a dissociated state under the influence of ketamine, to see a familiar face, your mind completely locks on that, and you say, I'm okay.
Yeah.
It's very helpful, and I encourage family members to stay there with a patient, especially the first one.
Okay, that's good to know. Now, next I want to hear another patient's story. So this is from our reporter, Erin Sullivan in Omaha, Nebraska. And she actually spoke to someone who's been using this for pain. So we've talked a lot about depression, but I kind of want to understand how this could be used if somebody's experiencing severe pain. Now, I do want to mention this story. Erin interviewed the woman at a tattoo parlor, because that's where the woman...
I saw that video.
Yeah, that's where the woman works. So let's take a listen to that.
Easy peasy, right?
This Fremont mom of two decided to pursue her dream career last April.
And I felt like it was a good middle ground for me to be able to connect with people while also creating meaningful art. Before, I would wake up in pain and live life in pain, and I'd only have so much in me I could give a day until I would push myself into a flare that would leave me in bed for a handful of days.
In 2020, doctors found a tumor on Eleanor Cook's cervical spine.
And it had eroded away and condensed my spinal cord over 60%.
Following neck fusion surgery, she had to relearn to walk and use her left arm. After all that, she still had debilitating pain.
Couldn't get a hold of or grasp on how to manage my pain in a way that felt safe or effective. Opioid pain therapy didn't feel like a good long-term solution, and other alternative pain management areas were not working.
In 2023, she found a treatment that took her life from black and white to...
It's every color. Sometimes I feel like I'm seeing colors that don't actually exist. It's very crazy.
Cook gets IV ketamine infusions at Mind and Body Wellness Center. Put simply, the off-label treatment is said to help the brain process thoughts and emotions more effectively.
When you go through ketamine, and when I went through ketamine, I had a perspective that I had never been able to force myself into, to see it for what it is and understand that that's part of the experience of why we're here. And it didn't feel like my pain was as daunting.
During the sessions, which last about an hour, patients experience dissociation.
You're not fully aware of your physical body, and you're kind of just hanging out in your own head for a while. But it's also a lot of internal visuals and processing of emotions, and sometimes I'm just relaxed the entire time. And yesterday I had a lot to work through, and I cried a lot, and that's what I needed.
After 6 treatments in 1 month,
I was like pain-free for 3 months. I had minor flares every once in a while, but they weren't long-lasting and they weren't very common or close together.
However, affording maintenance infusions about every few months for Cook proved a challenge. Infusions cost $400 to $500 per session and are not covered by insurance. Dr. Steven Salzbrenner at Nebraska Medicine says the high price keeps more people from having access to it.
But it's pretty widely accepted in the scientific community that it's effective, and so it's offered. Now, it's not often covered by insurance because it's not approved. If it was FDA approved for depression, then insurance might cover it as a treatment. But since it's not, it's kind of just done out of pocket a lot of times.
For the last few years, Salzbrenner has offered an alternative treatment that is FDA approved and accepted by insurance for depression, S-ketamine.
I've got some people that they tried every antidepressant they could think of. They're like 40 years old, and an hour after getting their first dose of S-ketamine, they say, I feel normal for the first time in my life that I can remember. And they never want to stop.
S-ketamine is chemically related to ketamine, but has a distinct chemical makeup. It's a nasal spray. And Salzbrenner says patients usually notice a difference the same day.
It can happen within like hours. It's really pretty remarkable because a lot of the traditional antidepressants we have take 6 weeks, 8 weeks, like before you really know if it's going to help.
It must be administered in clinic weekly. Some patients experience a short period of dissociation during treatment.
It doesn't happen all the time, and it's not linked to effectiveness. So if it doesn't happen, it doesn't mean the medicine's working.
Salzbrenner adds it's essential to couple the treatment with talk therapy.
Therapy is really indispensable. You can't replicate that with a medicine.
It's a sentiment Cook echoes.
I have a psychiatrist and a talk therapist, so I'm no longer taking any antidepressive medications, if my word counts for anything, as somebody who could barely get out of bed 2 years ago. I say try it.
So I thought that was an interesting story because not only was she using it for pain, but she did mention her antidepressant medication as well. So if somebody is considering this for pain, what would that look like? Like if I get in a car accident, I have an injury and the pain's not going away, or maybe I don't want to do opioids, like is that where this is an option?
You know, it's really an option for those patients who are already kind of at the threshold of being called chronic pain sufferers. We know that chronic pain, what happens is it centralizes, meaning it literally is a hardwired path in your spinal cord to your brain. So the sensation, the perception of pain is literally a part of the structures in your brain. What ketamine does, in very much the same way it does for depression, is in terms of reconstituting some of that neural circuitry and kind of increasing its flexibility to deal with things. It can reroute those signals, and it interferes with what we call central sensitization of pain and what's called the wind-up phenomenon. So the pain medicine folks would know a lot about this. So we're seeing that with neuropathic pain, with migraines. We're seeing it with what's called chronic regional pain syndrome. So we have patients who have an innocuous injury or trauma to their shin. A softball, one of our patients, a softball hit her, and she has had pain to the point where she wanted her leg amputated. Wow. And so that's a very, very tough nut to crack when it comes to the medical field. But ketamine has kind of re-altered the circuitry in her brain, and it has absolutely addressed those things. I would not say ketamine was appropriate for acute pain from, say, a contusion or a sprain or anything like that. It just wouldn't be. It's really for those chronic pain patients.
It's just not going away.
Exactly.
Okay, good to know. Now, also, she had mentioned, that she had tried antidepressants. They weren't working so well for her. But I wanted to get on the topic of Spravato. So
Sure.
that is an FDA-approved medication that you can take. That's something the doctor mentioned in that story, S-ketamine. So can you explain what that is, and then do you offer it?
We do. So Spravato is the first FDA-approved ketamine form as a nasal spray. You're right, S-ketamine refers to one direction of it. So there's two types, S-ketamine and R-ketamine. It's kind of right and left in terms of how the chemical structure is. And so that was approved because it's the more potent version of ketamine as opposed to R-ketamine.
Oh, really?
And so they did their studies. They did them right. Johnson & Johnson did this. They got it approved. And what it is approved for now is refractory depression, it's a major depressive disorder that's refractory to a couple of agents that they've tried, be it a Prozac or Celexa or what have you.
Basically prior medications failed.
Right. And acute suicidality. So they've added that indication recently, which is
that kind of opens up the door for more people. Like,
absolutely.
Because I think the problem with antidepressants, it takes a while for it to take effect.
Often 6 to 8 to 12 weeks.
If you're suicidal, you kind of need something immediate,
Exactly right. And that's one of the, in the literature, ketamine is described as being ultra rapid in determining, is this going to help your depression or suicidality or not? So we've kind of got a game changer, even in emergency medicine, where if someone was suicidal, I cannot send that patient home. I will tell you that giving, not the nasal spray, but giving some IV ketamine and having a period of 6-8 hours with a patient, I've been able to send some of those patients home with very, very close follow-up.
Like they were suicidal before they came.
They were articulating suicidal ideation, and with a single dose of ketamine in the emergency department, it has worked. Wow. Of course, I ensure very, very close follow-up, and it's a trustworthy
this wasn't
patient.
this was in the ER.
This was in the emergency department.
Wow.
That's right. You asked about, do we have Spravato? Yes, we do. We have gotten approved to do that. So that is a treatment where you come in. We have the medication in the office, and it has to stay in the office. And so the patient will self-administer a spray to each nostril, and then we monitor for 2 hours. And after that, they're not really allowed to drive or swim or sign contracts or operate machinery, that sort of thing. So we do now have Spravato in our clinic. And we want to offer it to our veterans. So we do have that. We don't have a lot of patients yet, but that is the one that is now covered by most insurances. So we're excited to be able to offer that. It is certainly different from IV ketamine, but it's got great results when it comes to treating these disorders that people deal with.
What is off-label? What does that mean for a medication?
So off-label simply means that the FDA has not reviewed enough information, data, or studies to give it a clinical indication that it could say, okay, it's for this. Spravato is now the exception. Johnson & Johnson did the work. They submitted the studies. There was clear and convincing data that this is superior to a placebo, and that's kind of how you design those studies. So they have clear and convincing evidence that it can be helpful for the treatment of the things that are indicated. I think they have enough information to do the IV form and do it. I think it's almost a travesty that they haven't done that. And I think it's certainly, I think it's wrong that the insurance companies don't yet cover this because we have enough evidence. We have 25 years of this literature to show it's safe. It prevents complications, it prevents suicides, and it treats these things that are otherwise refractory. So the fact that we use it off-label, we do that all the time in all kinds of medications. We still have to be smart about it. We have to use our clinical judgment as physicians and nurse practitioners to make sure that it's the right candidate and we do it the right way in a safe manner. But we can use that to our advantage. But you're right, the problem with that is
the cost.
The cost.
How much does one session cost?
So we've pushed our prices down in our clinic as much as we can. It's, nationally it was anywhere from $400 to $800 per infusion. We've pushed ours down to $300 per infusion. For the Spravato, we haven't quite figured that out yet, but being with insurance, that's why we got to work on those numbers. So we have tried to push it down to make it as widely available as we can, and we give a 10% discount to first responders and veterans for sure, because all of us are veterans who started this clinic. So we have a special place in our heart for them because of the fact that they suffer so much. One of the things you sent me was the fact that veterans make up 6% of our population, but 22% of our suicides. We lose 17 veterans a day to suicide, 133 Americans a day to suicide. And ketamine is, I think, a game changer. And in the first paper that came out on this in 2000 kind of mentioned that. It might be the most significant thing in psychiatric medicine in the last 50 years. I agree with that.
Now, you said it's been out for 25 years for depression, as far as like studies and stuff like that?
It's when they started realizing this thing has some potential to treat depression in an ultra-rapid fashion, yes.
Do you think, because right now ketamine, it's more of a generic in its IV form, correct?
Yes.
Do you think there's not money incentive to get it FDA approved? I mean, there's just not a financial incentive for these pharmaceutical companies to say, hey, I'm going to take this form of it that's already generic and get it approved, because they just can't make as much money.
That certainly always plays a role, no doubt about it.
Yeah. Whereas S-ketamine, it is a little bit of a different form. So
yes, and it's expensive.
They have 7 patents on it or
That's
something
right.
like
It's
that.
expensive, but I'll give them credit. As we've set this program up in our office, they have 3 programs that can reduce cost to almost nothing, and then again covered by insurance. Sometimes it's just the co-insurance or copay.
Yeah.
So we're trying to still figure that out, but I think it's absolutely appropriate to offer that as an option for patients, and we're excited to do it.
Now, since this is off-label, like, how do you know that when you go to a clinic, you're getting the right amount? Like, it's not too much, because that's what happened with Matthew Perry. He had a high dose.
Extremely high dose.
Extremely high dose. I mean, this could be anesthetic, so it can literally knock you out.
Right.
He had an extremely high dose, became unconscious. He was sitting in a tub, and then he drowned in his tub.
That's right.
That's all according to the court documents. So how can you ensure that, like, when you go into a clinic, they're giving you a safe amount?
Right. I ask exactly what am I getting? I would tell you that most are kind of driven by your weight. So you would get anywhere from 0.5 milligrams per kilogram or 1 to 1.5 milligrams per kilogram. And so that's what we do. That's a very safe dose. That's low dose ketamine.
Is there like a guidance somewhere that says like that's how much you should do?
Yeah, the literature.
Okay.
The literature says that, and at those levels, it's very, very safe. Again, the safest drug I've ever used. Matthew Perry had 3,540 nanograms per milliliter of ketamine in his system when they did the autopsy. That is
like, how many times is that what you should have?
35 times, easily.
Is that
or
like
more,
as much you give
times.
To like knock someone out if they're
Yes, that is full sedation.
Yeah.
And some of the toxicology reports on Matthew Perry reported that at that rate and at that level, you'd lose the ability to even stand up. You're unconscious, and in a hot tub, it's the absolute worst case scenario, and then he drowned. And so I think the postmortem indicated acute ketamine effects. Certainly the main cause. It wasn't the ketamine itself, it was the unconsciousness at the level that he was.
That caused him to drown.
And he got 27 shots of ketamine over the last week of his life. His last words were, "Shoot me up with the big one," to his assistant. And unfortunately, this is where ketamine, even with doctors involved, he had 2 doctors involved who were giving this to him, making money for all the wrong reasons, unethical, illegal, and they'll spend time in jail, and they should never practice medicine again. It's a tragedy. It wasn't necessarily the fact that he was using the ketamine. He was using ketamine unsupervised by an assistant who had no experience or training whatsoever in a setting where you would never want to use a medicine like ketamine, a hot tub. Yeah, exactly. So it's tragic, and we can learn from that. But you asked, how do you find out? Ask what I'm getting. Mm-hmm. Ask what is the lowest dose that I can get to get the effect that I need to get the therapeutic effects of ketamine, and you don't need any more than that. And so ask, be inquisitive. Any physician or nurse practitioner out there doing it should be able to answer every question about that and every concern you might have. And if they can't answer it, I would run away.
Now, I want to come back to the cost. So you said $300 a dose. Now, if you can get Spravato covered by your insurance and that works for you, that might be another option that's more affordable. But let's go to the $300 a dose. How many doses do you need? Is it like, I heard it's 6 to start? 6.
So we call that the initiation phase. Mm-hmm. So that's the first couple of weeks. And reason we want to do it that way, as I mentioned earlier, each infusion builds on the last. So we want to give it to you and let you understand the experience, make sure you're comfortable with that experience. Mm-hmm. The dissociation experience is weird. And then we're doing that in say maybe a Monday, Wednesday, Friday, Monday, Wednesday, Friday. So get 6 infusions in a 2-week period.
Wow.
Because we're going to find out by the next week if it's going to work.
Okay.
That's the beauty of it, is we don't have to wait that 6, 8, or 12 weeks that a new agent you take orally might take to even see if there's any change. So we get an idea of what the response is going to be very quickly, and a patient then decides, do I want to keep doing this or not? As soon as we do the initiation phase, we go into maintenance phase, and what our job is to do is to space that out to whatever the interval is, and that varies from patient to patient.
Could you ever stop taking it?
Sure. I treated my own mother, who's given me permission to talk about her case.
Okay.
I did her initiation. I think we went to number 7, 8, and 9. That was 2.5 years ago. She has not needed another infusion. That's atypical.
Okay.
Most patients, I would say, settle into doing the initiation phase, and they probably need to come back to the office and get an infusion every 3 months. 3 months. So if you're seeing us,
so then it's a little more affordable if it's every 3 months. Okay.
Right. And if you're only seeing us once a quarter and you're out there living the life you deserve to lead, then we've succeeded. Now, we would love to infuse our way out of a job with you and let you just be living your life. And in my mother's case, it seems to be the case. Yeah. But I would say most settle in at 3 or 4 months. And I tell them, I enjoy your company, but I don't want to see you in here if you don't need to be. Come back when you need us. And they know that we will get them in that day or the day that follows, so that they don't wallow down suffering from depression. But they come back, we get them topped up, they go back to living their life.
So for a lot of people, they can kind of wean down. And then, like in your mom's case, the rare case, you can actually stop it, which I mean, that'd be great.
I would imagine she may need one in the future, and it's easy. I know her dose, I know her rate, and we'll treat her. But so far, we've been lucky.
Now, I did ask one of the patients if they thought this could be addictive in any way, where people would seek it outside the clinic. Have you ever seen that?
So there can be a psychological dependency that develops. There's really not a physiological.
Physical, but yeah.
So in the sense, I think of those sorts of problems like alcohol dependency. Alcohol dependency, if you stop drinking abruptly, you can die. The sickest patients I've ever treated in my life in the emergency department were alcohol withdrawal. Similarly with benzodiazepines like Xanax, Klonopin, that sort of stuff. That's not a medication you want to stop abruptly. Those need to be weaned off over time, and they need medical management. So that same sort of thing is not true of ketamine, especially in the way we're using it. I have had a patient or two that I've had to have a candid conversation with and say, they're like, I can't get by without this. Yes, you can. And the point of this is so that you can. And if you think you need it, then we got to recalibrate. We've got to come to an agreement. We've done that successfully, where they might want it more often than I'm willing to give it. But we come to the agreement that I will do this every 2 months for you, but no more than that interval. And that's worked out just fine. So psychologically, people can think they need it and think it's necessary for them to kind of carry on in their life. I think part of our job and incumbent upon us is to have the conversation with them. It's like, no, you're doing well. And you've got support out here with your family, your friends, and your peer group. I want you to take advantage of that. Ketamine is not the solution to all your problems. It opens a door or it opens a window, and the ketamine helps just clear the vision out that window and how to go about your life and to process those problems you have differently in a more productive way.
Now, the last thing I want to ask you is about the future of psychedelic drugs. Maybe this could get more FDA approval. Obviously, we've already had it with Spravato, but there's other drugs being studied. So what's in magic mushroom, psilocybin. That's being studied for depression, PTSD, and drug addiction. Ayahuasca, which is a plant from South America, and then MDMA, which is in Molly or ecstasy. That's also being studied for PTSD. So where do you see the future of psychedelics?
I think it's bright as can possibly be. I'm excited about it. I love to read the literature as it comes out because there's more and more research on this. Psilocybin, I think, is the next one in the pipeline that I think could be another huge game changer. In fact, if you look at the studies that I've looked at, and I've looked at quite a few of them, I think psilocybin has the potential to be even bigger than ketamine in terms of the length of duration of remission of symptoms. Some of the studies, I think some Dutch studies showed that after a single treatment or dose of psilocybin, now that's a longer period of time, a 6 or 8 hour thing, they have had symptom-free patients up for 6 months. So that would be a phenomenal development if we could get that approved. I think Oregon allows the use of psilocybin. Colorado, I think, is rolling it out.
Wow.
Here in South Carolina, we're not there, not by a long stretch.
Okay.
But there are phase 2 and phase 3 studies going on with psilocybin, so it's not too far away, I think. And it'll be very helpful and therapeutic, done again in the right place. Not just taking it at home and having a trip. Psilocybin, unlike ketamine, we talked about a therapist with you, psilocybin actually lends itself very well to that. So what I hope to do ultimately is have psilocybin as a therapeutic alternative and have psychotherapists, psychologists, counselors in the room with them for about a 3 or 4 hour period to kind of do the talk therapy that can be enormously helpful at the same time as they're getting the psilocybin. I hope for that.
I feel like we could do a whole podcast just on those three.
We could. I mean, they're just cool drugs.
Yeah,
and they do incredible things. They have incredible effects. MDMA, you asked about that. Yeah. Ecstasy is being studied. Almost got there. A company called Lycos. Their study, the structure of the study was not particularly good, so they got turned down by the FDA, and they were fast-tracked to get approved for this stuff. They're kind of retrenching and re-looking at their way they did it, and they're going to resubmit. So I think MDMA is close, but the studies that they submitted to the FDA were not good enough. And so they've kind of taken a step back on MDMA, but I think it's coming because, again, very encouraging literature suggests that, especially in vets with PTSD, because that's kind of the subgroup they started with, it has been very effective and very rapid onset, much like ketamine and psilocybin. And it would certainly be applicable to the patient population that aren't veterans. PTSD is a phenomenon that grows in our ability to recognize it as a syndrome that we can treat and get ahead of.
Yeah. And what about ayahuasca?
Ayahuasca, same sort of thing. You know, you're going to get a psychedelic experience, hallucinogenic and real change in perception, kind of the dissolution of the ego, the superego, and just down to basic first principles. So it kind of allows that same sort of dissociation experience you get with ketamine. And that just seems to be the reboot that the brain and the mind needs to do the same thing. Neural circuitry being re-knitted together, and it just changes the way you process
It's trying to
life.
find how can we find the right dose of a lot of these things so it's used in a positive way.
Right. Ayahuasca, you know, I haven't read a lot of studies where they're doing them, but I haven't read how they're doing the dosing. What they're trying to do is isolate the active ingredient, kind of get rid of all the other stuff, and then test that versus placebo and say, okay, well,
Kind of like how they did with psilocybin, because that
Exactly.
was magic mushrooms.
Exactly. Exactly right.
Great. Well, thank you so much for joining us
Thank
today.
you for having me.
Any other last minute thoughts you want to give to people?
You know,
listening?
I would say that, you know, what I've learned from this, and I would never have guessed I'd be a ketamine physician if you'd asked me 6 or 7 years ago, but there is hope. And what I see is I see psychiatrists sending patients to us because they've tried everything. They've worked hard with these patients, and the drugs that they've used just don't work anymore, or they plateaued, or they have side effects. And ketamine is a chance to turn a corner. And to get back the life that all of our patients deserve, and what we want to help them get to. It is not a panacea, it's not a cure-all, but I have seen it work in patients to where it just kind of cracks the door for them to see how to process the issues that life throws at you, and to deal with those things in a very positive way so that we're kind of moving upwards instead of a spiral downwards. And it is miraculous, is what I've seen in our clinic. And I've read in the literature across the country and around the world. So I would say talk to your primary care doctor, talk to your psychologist, psychiatrist, and ask if this is appropriate for you. Because it's not for everybody. But for those who have struggled with this for most, if not all of their life, then it certainly deserves some research and a chat with us or their doctors about whether or not we should do it.
Well, thank you so much for
Thank you
joining
for
me
having
on the Wellness Files. Thanks for being here. We
Sure.
really appreciate it.
Glad to be here.
Thank you for listening to the Wellness Files podcast with Carrie Beal. If you like what you heard, make sure to follow, subscribe. If you're watching on YouTube, you can save this playlist and then you can come back to it anytime you want. And of course, you can comment if you have any questions. You can contact me if there's a topic you want me to cover. And of course, we really appreciate you listening.